This is from the Research Capacity Building Committee, which holds every month, third or fourth Saturday, statewide journal club as a part of this. And we are fortunate enough to have a support from the IPS Tamil Nadu chapter under the leadership of Dr. R. Sabrin Ross and other office bearers of the Tamil Nadu State IPS chapter. Today we have selected a guest speaker who is well known for his a research activity, eminent researcher. This eminent researcher comes from the Central Institute of Psychiatry from CIP Ranchi. This CIP Ranchi is one of the oldest and one of the largest hospital for psychiatry in Asia, and it produces a lot of good research articles, and mainly they are into neuromodulation and neuro investigation techniques. We are fortunate to have with us our Dr. Nishant Goyal, and as usual we select one of the article published from the researcher, psychiatric researcher, and will be presented by one of the PGs, and after that we'll have discussion. Followed by that there is a guest speaker who will speak on particularly on this topic and related to the journal or any related choice of his field. Currently the topic is chosen as basics of EEG as applicable to psychiatry. Now I welcome all the members of the Tamil Nadu State IPS, and also most importantly the postgraduate students who are likely to beneficiary of this statewide journal club. Now over to Sir Dr. S.R. Nirmal to introduce the guest speaker.
Thank you, sir. Thank you. Dr. Nishant, as sir was saying, is from the Premier Institute, CIP. So the moment I think of CIP, I remember 2000 when I went to write entrance there, and I was not fortunate enough to get a seat there. So then I did from Vellore, and so we all know it's one of the oldest and premier institutes in India, catering to psychiatric research and other institutes. And sir has graduated, and he's the head of the child psychiatry department at the CIP Institute, and he's the program coordinator for a lot of issues. And he's been active in many societies, including Neuromodulation Society of India, and he's been active in research and other activities. He's been a editor of the Journal of Psychiatry, Eastern Journal, and other child psychiatric journals. And to his cadre, his accolades, he's got a lot of publications, more than around 150, and he's received a lot of awards, including major awards. And he's done his area of interest is in neuromodulation, as Shivanand sir was saying, and he's got achieved a lot of fund for the institutes. He's been a fellow of major institutes like DBT and others, and his interests, we're happy to hear and see published articles in his research. He's done a lot of research in EEG, and today we'll be going through one of his articles, and sir will be presenting about EEG antipsychotics related EEG changes. And we are all eager to hear, like other postgraduates, and hope it will be a very good, it will be academic feast for all of us, and eager to listen to sir. So will Dr. Farhan, over to you. Can we go to the presentation directly, sir? And probably Dr. Shankar and Manishri ma'am will take over from here. Thank you.
Good afternoon, everyone. Today, I'll be presenting the Journal Club. I am myself Farhan, doing second year PG from JIPMER. The journal of today is Psychiatry Investigation, published by Korean Neuropsychiatric Association, which was established in 1976. And the current chief editor is Dr. Hyun Kook Lim. And the publications are done monthly in the fields of psychiatry and related neurosciences. And the journal is indexed in PubMed, Scopus, Google Scholar, and other journals with a journal impact factor of 1.8. The article of interest today is Electroencephalographic Abnormalities in Clozapine treated patients, a cross-sectional study, with primary author being Dr. Nishant Goyal. To introduce the topic, Clozapine is a dibenzodiazepine with blocking activity in D1, D4, D5, and 5-HT1A and 5-HT2 receptors. Clozapine is less likely to cause extrapyramidal symptoms, however, has more propensity to cause severe adverse drug reactions like agranulocytosis and high incidence of seizures, amounting to around 1.3 to 2.8% in the literature. There is also some evidence for dose-related effect of clozapine on seizures, and these seizures have been found to be more common in state hospital patients and brain-injured patients. Also, with respect to EEG abnormalities in clozapine-treated patients, literature tells that it's around 53 to 74%, with generalized slowing being more common finding than epileptiform activities. Some studies also show EEG changes to be dose-related, and clozapine may predict pathological EEG changes and occurrence of seizures as per some studies. So the aim of the current study is to explore and characterize the EEG abnormalities associated with clozapine treatment. Going on to methodology, this is a cross-sectional study held in Center of Cognitive Neurosciences in CRTP Ranchi with a sample size of 87 patients who were on clozapine treatment. This patient received clozapine for at least 2 weeks, and if there were any history of seizures in the recent past, they were excluded from the study. With respect to how EEG was measured, digital EEG in awake state with eyes closed was measured using 32-channel Neurofax EEG 9000 as the equipment. EEG placement was according to International 1020 system with reference leads as the ear electrodes, and provocation test of 3 minutes of hyperventilation and photic stimulation at different frequencies were tried. With respect to how it was analyzed, visual analysis of the EEG by the primary author was done. More importantly, to characterize the background activity, whether there were slow waves, and to look for epileptiform activity, whether it was spike, polyspike, or sharp waves. And these EEG abnormalities were categorized broadly based on 95 to 100 epoch, which is the total time duration for which the EEG abnormality was assessed. And based on for how much time duration these EEG abnormalities persisted, they were categorized into mild, which was less than 25 epoch, moderate, which was 25 to 50% of the epoch, and severe, which was more than 50% of the epoch. Going on to statistical analysis, it was analyzed using the SPSS software with continuous variable analyzed by independent t-test and categorical variables by Pearson chi-square test, and logistic regression analysis with backward conditional method was used with outcome variable as presence or absence of EEG abnormality, and predictor variables being age, gender, clozapine dose, duration on clozapine, and other medications. Going on to results, with respect to sample characteristics, predominantly it was male gender amounting to around 87% with mean age of 32.76 years, and all were right-handed. And the mean duration of the illness was around 92.39 months, with schizophrenia amounting to be the most common diagnosis, around 72.4%, with mood disorder and schizoaffective disorder being the other diagnosis. Also, around 6% had past history of epilepsy, and around 3.4% had past history of head injury or CNS infection. With respect to medication characteristics, mean clozapine dose was 293 milligram, while the mean clozapine duration was around 15 weeks. And with respect to what medication the patients received, around 64% received only clozapine, while 21% received valproate, 8% received other antipsychotic, and antidepressant were received by around 6%. This was in addition to clozapine drug. This is the first table showing the frequency of EEG abnormalities in the patients, in the 87 patients who were on clozapine. So out of the 87 patients, around 55, that is amounting to 63%, had EEG abnormality, and around 41.4% had abnormality of slow waves, out of which the most common was generalized slow waves. And if you look at the type of the slow wave, theta was the most common wave. If you look at epileptiform activity, it was also in a similar frequency of 41.4%, which is same as the slow wave incidence. And also similarly, it was found more common as generalized epileptiform activity. With respect to severity, mostly moderate severity was the most common, second being severe, and mild was relatively less, for amounting to around 6%. And when they looked at EEG abnormalities based on Clozapine doses received, if the dose was more than 300, around 66.7% had EEG abnormalities, and going on to less than 25%, which amounted to around 57%, which was more or less similar even in between the range also. With respect to medications received, if they were only on Clozapine, EEG abnormalities were present in around 67%, while with valproate it was around 57%, with antipsychotic it was around 42%, and with antidepressant it was around 60%. Now, when they looked at the two groups, that is the patients who had EEG abnormality and who did not have EEG abnormality, and when these group and the difference between these groups were analyzed in terms of age, duration of illness, Clozapine dose, duration of Clozapine, gender, diagnosis, and psychiatric illness, when all these components were taken into consideration, it did not find any significant difference between the two groups. Subsequently, logistic regression analysis was done with the outcome variable as EEG abnormalities present or absent, and it showed that considering all the predictor variable, namely age, gender, Clozapine dose, duration of Clozapine, as well as medication status, it did not show any significant finding with respect to any association with the presence or absence of EEG. Going on to discussion. So the overall frequency of EEG abnormalities was high, around 63.2% in the study, which is similar to other studies in the literature. And unlike other studies which showed slow waves being more common than epileptiform waves, this study showed both of them to be equal, amounting to around 41.6%. And EEG abnormalities, even at low doses in the study, imply that there is an absence of a dose-dependent relationship, at least in this study. And EEG monitoring is hence underscored as changes are present even at low doses, although these changes are non-specific and not associated with any seizures. Also, it has been observed that Asian patients have higher plasma levels with the same dose. Hence, ethnic variations may account for EEG abnormalities even at low doses in the study. Also, there is less evidence for direct relationship between Clozapine levels and seizures, and many studies show no association between EEG and seizures, while there are also some studies which show the opposite. Hence, more studies would be required to confirm this. And EEG changes also have been associated with other antipsychotics like haloperidol, olanzapine, risperidone, and so on.
Okay, sure.
Some evidence of predictive ability of EEG abnormality have been present for favorable clinical response. Also, there is no consensus data on utilization of EEG data on dose optimization. Also, there is no particular consensus on anti-epileptic prophylaxis for patients on Clozapine. However, some reports advise that levels more than 500 microgram per deciliter or presence of epileptiform discharges on EEG as indicators to start prophylaxis. However, this study did not show any association between seizures and dose or EEG changes. Going on to limitations in the study, there was absence of baseline EEG, which prevents to differentiate whether these EEG changes were actually new onset or were actually already present in the patient. Also, there was a small sample size with heterogeneity of psychiatric illness, and serum Clozapine was not measured, especially given its inter and intra-individual variations for a particular given dose. Going on to critique. The title was self-explanatory, mentioning the type of the study, and the abstract was concise and provided a short summary. The aim of the study was clearly mentioned, and the topic explored a new novel topic. However, compliance to medications, whether it was self-reported or supervised, were not mentioned in the study, and details of other comorbidities of the patient was not mentioned. EEG was measured as per standard protocol and was evaluated by a trained expert. And confounders like medications and demographic details were considered in the analysis. However, other confounders like benzodiazepine or other neuromodulation techniques like ECT and so on were unclear in the study. And also detailed discussion comparing the results to literature was done. Now, on applying the critical appraisal tool for cross-sectional study by the Johannesburg Institute, the first question being, were the criteria for inclusion in the sample clearly defined? I put the answer as no, because the only statement that I could find in the study which amounted to the inclusion criteria was the patients were on Clozapine for at least 2 weeks. Whether this was IP patients or OP patients, what was the age criteria of them, it was not given in detail, which is why I put as no. And for the question, were the study subjects and the setting described in detail? Yes, it was described in detail in the study. And was the exposure measured in a valid and reliable way? For this, I put as unclear because the details are not clear in the study. The exposure, that is the Clozapine, can be either be measured on interview, whether it's supervised or whether it's self-reported, or it could be by a biological method of calculating the serum levels. For the next question, were objective and standard criteria used for measurement of the condition was present in the study? Were confounding factors identified? Yes, some of the confounding factors were identified. However, some like benzodiazepine and ECT and so on was not mentioned in the study. And were strategies to deal with confounding factors stated? Yes, these factors were included in the logistic regression, which can account to one of the strategies to deal with confounding factors. And were the outcome measured in a valid and reliable way? Yes, EEG was measured in a valid and reliable way. And was appropriate statistical analysis used? Yes, at the end, logistic regression analysis also was used. Thank you.
Very much for having me in today's journal club. First of all, I would like to thank Dr. Shivanand and everyone from IPS Tamil Nadu State Branch and all the PGs for them, for whom we are basically here for. So for having me today evening. So I was asked to speak on a topic of my interest related to the article which was presented today. So I told Dr. Shivanand that why not to talk about the basics of EEG as applicable to psychiatry. I'm sure all the people who are working in psychiatry, either they have or they use EEG for various purposes. So I thought that in the next 30 minutes or so, if I can share some basic tenets of how EEG is useful, how EEG is applicable to the practice of psychiatry, we can more formalize or crystallize what we have been doing in the last so many years. So thank you once again, and I basically also represent team Clinical Research Center for Neuromodulation in Psychiatry, which is a multi-centric project funded by Wellcome Trust DBT, along with NIMHANS Bangalore and KMC Manipal. So today we'll be talking about the basic tenets of EEG, its indications, prerequisitions, calibration, basics of normal rhythm, abnormal EEG, and lastly, how EEG is useful in psychiatric research. I'm not talking about clinical psychiatry, psychiatric research. So just a brief introduction from where this all EEG thing is coming from. This is not my introduction. This is the introduction of the department which I have been leading for the last 8 years. This is called KS Mani Center for Cognitive Neurosciences, where we have a dedicated setup for cognitive neuroscience studying. We have a full-fledged clinical as well as research EEG things. We have one of the most advanced neuromodulation labs or brain stimulation labs in the country. We have a first of its kind neuroplasticity lab in the country in a psychiatric institute, apart from other methods of cognitive neuroscience studies, which is both used for clinical as well as research purpose. So these are the machines which we were using. On the left hand side is an ERP machine. Right hand side is an EEG machine, old EEG machine. Now we have been using EEG like this. So you can see this is a 128 channel EEG recording going on. This is a 256 channel EEG recording which is going on, primarily used for clinical research. We also do task-based EEGs, or which are also known as event-related potentials. Today I'll not talk much about it because it's a complete topic in itself. Then we do a lot of EEG processing in our lab, which includes source localization using various softwares you can see on the left and right hand side. Then we do a lot of source monitoring tasks like fast Fourier transformation, coherence. I would like to inform you that the last 50 years, we have more than 70 EEG and ERP studies which have been undertaken in CIP Ranchi. This is a small list of what has happened. Few of the publications which we have in decent journals. Now coming to EEG. So first talking about the genesis of EEG, how this whole thing actually came up. Whenever we talk about EEG, we expect something to happen like this, alpha, theta, delta. But what we actually get whenever we are doing a recording, we get something like this. So this is a typical page which I have taken from our EEG machine. This is how EEG record looks like. This is a cross section. A cross section is also known as an epoch. Epoch is basically a time-bound phenomenon which has an onset as well as an offset. So very quickly, we all know who is Hans Berger. He was the first to develop EEG, which is the graphic representation of voltage difference between two different cerebral locations over a period of time. So he was the first person to describe alpha and beta rhythms in human beings. So as I say, EEG is considered as a window of the mind where the oscillation of electrical potential, which is generated by brain sources. We all know that our brain, the way our heart generates electrical activity, similarly, our brain also generates electrical activity. And EEG does provide a very large scale and a robust measure of cortical dynamic functioning. So whenever we talk of the content of EEG, we should know two things. One is an amplitude, the amplitude of the activity, and the frequency of activity. Depending upon the amplitude and frequency and from where they are coming from, it provides a lot of information about the brain state. And I'm sure you must be aware of the fact that to record death in a comatose patient, you have to do EEG to call someone brain dead. And a lot of EEG activity actually correlates with a lot of cognitive processes, which makes cognitive neuroscience a very, very interesting subject to read. I was talking about like how EEG is different from other modalities of neuroscience. So if you can see this graph, EEG, ERP, and MEG, they have a very good temporal resolution as compared to imaging techniques like PET, SPECT, or fMRI or MRI, which have got a good spatial resolution. So we'll see what is an EEG, what are the indications. I'll not talk about the instruction and other thing. So characteristics of an EEG signal, a signal of EEG, what does it represent? It represents four things. So electrical activity of the brain is basically the synaptic potential of a neuron, which can be a pyramidal cell, a glial cell, or an interneuron. So we see the change in the potential over time, which is known as time domain. We will see the oscillations which are occurring in various networks. This is called frequency domain. Then we see the location, from which location which electrical activity is coming. So this is called the spatial domain or the topographic characteristics, as we are talking about, the location. Then we see how one region of the brain is interacting with the other region of the brain, which is basically a measure of connectivity. Youngsters these days talk a lot about default mode network, executive brain networks. So EEG will give you a wonderful measure of functional connectivity between two areas of the brain, which is known as network domains. So apart from just talking about epileptiform activity, slow wave EEG activity, normal EEG, sleep EEG, this is how you can understand and decipher the activity of the brain. If you are interested in cognitive neuroscience and somebody wants to do research in cognitive neuroscience. The strength of EEG is that it is non-invasive. It assesses system-level states for which you don't need to put a person into an MRI gantry. It gives you millisecond time scale resolution, and it's a low-cost thing. A PET scan or an fMRI scan comes for crores of rupees. EEG is just available within few lakh. Good EEG is available within few lakh of rupees, and it is a very, very simple technique to use, providing wonderful information about the activity of the brain. So the indications of EEG can be broadly classified into clinical and basic and cognitive neuroscience indications. We usually do normal. Now these days we do digital EEGs, but when I started doing EEG, there was a paper EEG as well. At the same time, we do video EEG. We use EEG for the purpose of sleep studies. It's also known as polysomnography. And then, as I told you, task-based EEGs are also known as ERP or event-related potentials. Specific changes can be seen through EEG in cases of epilepsy. We can get those specific changes through video EEG when you have to differentiate between epilepsy and non-epilepsy attack disorders. We use a lot of activation procedures, which I'll be talking about. Non-specific changes can be indicated in terms of electrical changes in aging. Then suppose diagnosing delirium. I'm sure all of you must be knowing of the fact that delirium EEG is usually there is a generalized slowing or there is an intermittent delta activity. The only delirium in which there is fast activity in EEG is delirium associated with alcohol or delirium tremens. Then in dementia, sleep EEG provides a lot of information about Alzheimer's disease, Creutzfeldt-Jakob disease when you get a typical triphasic wave, Huntington's phenomenon where you get a gradual flattening of EEG, encephalitis, encephalopathy. A lot of talk these days is about autoimmune encephalitis and all those things. So again, these are some indications for EEG. Then neurologists usually do EEG for infarction, metabolic disorders, hypoglycemia, infections, so on and so forth. We in psychiatry, it's a very, very useful tool for seeing psychogenic non-epileptic attack disorders or dissociative conversions, as we call it, sleep disorders, particularly polysomnography, and neurodevelopmental disorders. So, as I told you, the basic of cognitive neuroscience indications we usually do is to understand the neurophysiology of the brain. So, in the psychiatric settings, we usually don't do intracortical EEGs, but people in neurosurgery, they do that. To understand cognitive functioning, we do a lot of task-based ERPs. These are certain waves you can see. This is called P50, N100, P300. I'll not go into the details of this, but for example, if you want to measure selective attention of an individual for a task, which is a very, very sensitive indicator of prefrontal cortical functioning, P300 or a positive wave after 300 milliseconds of a stimulus is a very, very useful tool. So again, this I'll not go into the details of this right now. Coming to the pragmatics of EEG recording, like what a person should know whenever you buy an EEG and when you ask a technician to record EEG for you. So these are certain books we follow at our place. Whenever you do EEG, you have to develop something like this. So this is known as basically a 10-20 electrode positioning system of, where you put electrodes. So by convention, midline is denoted by Z or Z, right-sided with even numbers and left-sided with odd numbers. So this is how you measure. I'll not go into the details of this. I do a workshop of around 4 to 5 hours just to teach all those things. So I'll not go into the details of all these things. So I'll quickly, move fast through this. So in the 1020 International System of Electrode Placement, this is the most simple way of looking into it. Towards the nose is called the nasion. The most prominent part of the occiput is known as the enion. And we put two electrodes denoted by A1 and A2. Basically, they are considered as electrically neutral points. So some people put that electrode on the pinna or the earlobe. Some people put this electrode on the mastoid process on both the sides. How do we understand the polarity? It is very simple to remember. The depiction of polarity is based on the convention that when the charge travel from more negative to more positive, the pen goes up or the recording goes up. And when the charge moves from positive to negative, the pen goes down. So the positive wave is down and the negative wave is up. We use arrangements of electrodes. As I said that for measuring any electrical activity, you need two electrodes. Suppose all of you must have made projects in your childhood when you were that how to use a battery to light up a bulb. So we need two electrodes, one a positively charged electrode and a negatively charged electrode. So two electrodes are known as a channel, and a system of arrangement of channel is known as a montage. Depending upon our requirement, we use different type of montage. Suppose if I want to understand the overall basic attributes of the normal electrical activity of the brain, we use monopolar montage or referential montage. And if I really want to see the abnormal electrical activity of the brain, I use bipolar montage. So whenever you buy a EEG machine, please make sure that you ask the technician to put at least 3 or 4 different type of montage through which you can just repeat and see the electrical activity of the brain. So this is a typical unipolar montage. You can see it over here. And this is a typical bipolar montage. There are n types of montage which are available overall. This is just a depiction of different type of montage. You can see on the lower left or left side, the montage which we use, this is called an ipsilateral montage, which is basically used to understand the morphology and the characteristics of normal electrical activity. Why? Again, I'll not go into details of this. On the right hand side, you can see this is called a CZ reference montage. To measure the electrical activity during sleep, we use this particular montage. So at least you should have 3 montages, minimum 3 montages in your EEG machine. One is a ipsilateral montage, one is a CZ reference montage, and one in the middle you can see on top. This is a prototype bipolar montage, which just look like 2 bananas placed along with each other. This is called a double banana montage. Apart from that, you can have any number of montages. You can, if you're more interested into all those things. Along with this, the way we do in ECG, we use calibration. So calibration is basically used to ensure that the EEG machine is fit for the purpose. The standard paper speed or the speed which is moving is 30 millimeter per seconds. When we do this, I'll show you in the EEG recordings which I have put up later on. There you will see some dark lines and some light lines. So the distance between 2 dark line corresponds to 1 second, which has got 5 equal distribution. So that 2 light line corresponds to 200 milliseconds. If you understand this, it's very easier to actually find out and understand that electrical or epileptiform abnormality. We use different type of filters to remove the unwanted frequencies. The most commonly to understand is called a AC filter or notch filter. Then we have low pass filter and high pass filter. So again, I'll not go to the details of this. You should keep the screen display. Whenever you are reading an EEG, you should keep the screen display at 10 seconds per page epoch. So accordingly, you can, when you use a software, it will give you all these options. Now moving on to the next part of it, which is talking about normal rhythms and artifact. It is very, very important to understand what are normal rhythms and what are the various attributes of normal rhythm. So I'll take another 10 minutes to actually take you through this session, and I'll request the organizers to stop me in between if they think that it is going too much. So you can always stop me at any point of time. So we use certain activation procedures as convention, and we should always use photic stimulation, where we provide photic lighting by a bulb sort of a thing while the EEG recording is going on. Then to understand, what is happening when the person gets hypoglycemic, we use hyperventilation, and some people use sleep deprivation. So this is the table for various waves. The normal waves are 4: alpha, beta, theta, and delta. So theta and delta waves are waves of sleep. Theta is for light sleep and delta is for deep sleep. So if you are getting theta activity or delta activity in an awake individual, they are abnormal. So you have to be very, very particular about that. We'll take up one by one. Alpha is basically 8 to 12 hertz with an amplitude of around 50 to 120 microvolts. It has a rounded sinusoidal morphology coming from the posterior brain when you are calm and relaxed with eyes closed. So it is coming from the occipital region or the temporal region or the parietal region with a typical morphology. When you have closed, the moment you open your eyes, alpha gets disappeared. You can see it's written over there. Sorry. So usually by convention, we remember that alpha starts to develop by 3 years of life, and by the age of 10 years, 10 hertz alpha is completely developed. So you can see how does a typical alpha wave looks like. Again, one more slide on this. Then a very close counterpart of alpha is a mu wave. Similar frequency, similar amplitude, but they typically come from central region. And the polarity is different. Now they have a sharp negativity and rounded positivity. I'll show you in the next slide. Now, importance of mu activity is that for psychiatry is that mu activity is a direct indication or a direct indicator of the functioning of the mirror neuron system or the mirror neuron activity, which are implicated in the empathetic conversation if a person is having. If you want more details, we can discuss it later on. You can see how the mu activity looks like. Over here, you can see in the box which I have marked. Then coming to beta wave. So this is a fast activity with a low amplitude coming from the anterior part of the brain with eyes open. Mind it, alpha was eyes closed. This is with eyes open. Usually benzodiazepines, they accentuates beta. So whenever your patient is on benzodiazepine, please see whether you are not measuring beta waves as an abnormal beta wave activity. So this is how a beta wave looks like in the EEG recording. You can see the small waves, particularly coming from the frontal, central, and other regions. Again, one more slide onto this. Then theta waves. As I told you, theta and delta are basically waves normal when the person is sleeping or going to sleep. So theta waves basically have 4 to 8 hertz wave. Amplitude is similar to alpha waves, particularly coming from central region in light sleep. See how they look like. Now you can see the montage on the left side. All the electrodes are referring to CZ. I was talking about the CZ reference montage. So the same activity you can see across all the leads over here. Quickly about delta waves. Delta waves are basically waves of deep sleep. Usually in an EEG recording, you don't get delta waves unless until there is a small child whom you have sedated giving benzodiazepines, or barbiturates. So they are very high amplitude activity coming from central region. Again, see how they look like. Again, you will see this looks like an abnormal EEG, but when you see with the person was sleeping with medications, this is how it looks like. This is how delta waves look like. Important thing to understand is that in any given EEG recording, more than 70% of the activity is such that you cannot make head and tail out of that. So we mark them as indeterminate waves. So you call anything alpha when you have all those attributes: the frequency, the amplitude, the location, the reactivity of the alpha wave, and how it is basically behaving at a particular region. So 70% of the EEG activity in any given EEG are basically indeterminate waves. Quickly moving on to artifacts. Again, you cannot read an EEG when you are not aware of artifacts. We all understand what are artifacts. Artifacts are there in everything. So these are unwanted noise signals which can be physiological or non-physiological. For example, pulse artifact, I'll show you one by one. Pulse artifact, deglutition artifact, eye movement artifacts, these are all physiological artifacts. Any artifact which is coming from the AC source. Suppose, what I mean to say is all the EEG machines are connected to our electrical mains, right? So when any voltage fluctuation or any change in the frequency of the alternating current, it spills into the EEG as something called 50 Hertz artifact or notch artifact. And that is why to ward off that, we use notch filter or AC filter, which I just talked about previously. Then because of bad electrodes, you can have electrode artifacts, head movement artifacts, so on and so forth. So first talking about eye movement or ocular artifact. So they are typically seen in the frontopolar leads on the left and right hand side. The physiology behind it is that our cornea is assumed to be positively charged and our retina is assumed to be negatively charged. So whenever you move your eyes up, they say that the positively charged cornea comes closer to the frontopolar leads. So the charge moves from positive to negative, causing a negative deflection. See over here. If you see very carefully, so there is a negative deflection over the frontopolar leads on both left hand side and right hand side. This is a typical depiction of ocular or eye movement artifact. One more slide on this. Then cardiac artifacts. At times, because of the location of the electrodes, we get things like this, which corresponds to the heart or the QRS complex of the ECG. So these are also known as pulse artifact or ECG artifacts or cardiac artifacts. They are synonyms which can be used. At times, people flex their muscles, particularly of the frontal and temporal regions, which produce a high frequency spiky artifact. These are known as muscle artifacts. You should not jump to reporting anything abnormal seeing all these things. Then at times while the EEG recording is going on, we do deglutition movements. So these are usually small deflections which are bilaterally symmetrical. See, this is how deglutition artifact looks like. Then when the electrode is bad or when your technician is not seriously or he is in a different mood, they will not put your electrodes properly. So this is how an EEG will become when the electrode is not placed. And at times electrodes, they go bad. So you have to keep on changing the electrodes. Electrodes are basically silver chloride electrodes which go bad after a particular number of EEG recordings. So you have to keep on checking for that. I've already talked about 50 Hertz artifact. See how this is how it looks like. So then some people who are uncooperative or uncomfortable, you will get bizarre artifacts of high amplitude look like this. It's commonly seen in actively psychotic patients, which we come across a lot in our center. If you don't have a good air conditioning at the place where actually recording the EEG, people tend to sweat. and sweat is basically, it has salt. When there is salt, it produces a bridge between two adjacent channels, which produce a very low frequency and amplitude swaying sort of a movement, which is known as sweat artifact. You can see it over here. Now, quickly moving on to the next part of my presentation, which is basically about abnormal EEG. I have not, because I was giving 30 minutes, so I have deliberately skipped on the EEG changes of sleep. So if anyone is interested, we can talk about it some other time. So abnormal EEG. So what is abnormal? Number one. So anything which has a spike or a sharp wave paroxysmal activity with either focal or generalized. One. Another can be slowing of the background activity, again, which can be focal or generalized. So this is how you classify abnormal activity of the brain. So clear-cut paroxysmal activity, I hope you understand what is a paroxysm. Paroxysm is an event which comes in a otherwise normal background, which is comparatively easy to understand, but at times it is difficult to describe without the context of background EEG activity. And my dear friends, that's why I keep on teaching my residents and students that to become or to learn to report abnormal EEG, you have to master to understand the background activity of EEG or the background normal activity which is happening in the EEG. Otherwise, most of the people, they report artifacts as abnormal activity. You have to have the clinical parameters. Without that, you cannot report any EEG as abnormal, and the condition of the subject while you are doing the EEG recording. If a person is sleeping, you will find a lot of sharp waves, which you might report as abnormal, but they are actually vertex sharp transients. And also it depends upon the quantification rather than the qualification. At the end of my presentation, I'll give you certain rules to call any abnormal activity as abnormal. So you'll understand more when I'll talk about that. First, coming to spike. So it's a transient wave with a pointed peak having a duration between 20 to 70 milliseconds. So I was telling you about dark and small. I'll just go back for a moment. Yes, you can see in this EEG, there are two lines over here, this and this. So these are considered as dark lines. Sorry, these dark lines, and in between there are 1, 2, 3, 4, 5. These are light lines. So this to this is 1 second, and this to this is 200 milliseconds. So any spike will be less than 1/3 over here to call it a spike. I hope I'm making sense to all of you. If not, I'm sure I can take questions later on. So spike can be of any type, but main component of spike is the sharp negativity, which actually occurs while interrupting the background activity. You cannot have normal spike activity on the background. It has to interrupt the background activity. Sharp wave is a bit different from spike, again coming outside the regular background with a duration ranging from 700 to 200 milliseconds. Again, you see over here. See? So this is two dark lines, light lines. So more around this activity is between two light lines. And both spike and sharp wave have equal etiological significance. Then we have polyspikes also. I'll not go into the details of polyspikes. So this is how they look like. By convention, in most of the cases, unless proven otherwise, spike and sharp waves are usually followed by a slow wave or a slow potential, which are usually the electrophysiological processes of or the correlates of inhibition. Once neurons fire very fast, they go into hibernation for some time. Spike and a slow wave. The difference between spike and sharp wave is the duration of potential reflecting the distance of the neuronal origin of the potential from the surface recording. Then coming to EEG slowing. So slow waves, as I told you, can be theta or delta, right? if they are not occurring in the context of sleep. So for correct identification, it is very, very important to perform EEG recordings during waking states, and the person should not be drowsy. So slowing basically reflects a decrease in the responsiveness or neuronal excitability, either due to loss of neural activity, suppose in the context of dementias or delirium, either abnormal neuronal networks commonly seen in post-stroke patients or epilepsy, or at times in psychiatric conditions like schizophrenia or other severe mental illness, or due to impaired metabolism, supposedly hypoglycemia. So these are how you get, these are slow activities, how they look like. So this is a recording from our center. These are diffuse slow waves which are present across all the channels. Focal slowing, again, I'll not go into the details of this. Focal slowing at times are very, very sensitive indicator of space occupying lesion in the wave, in the brain. For example, if you see at the bottom, there's something called FIRDA, F-I-R-D-A, which stands for frontal intermittent rhythmic delta activity, which is usually associated with encephalopathic or toxic or metabolic event. So this is how you can see in a 61-year stuporous patient, this is how a FIRDA looks like. Again, as I told you, location is a very important goal to localize any abnormal activity, and you need bipolar montage to locate such waveforms. You can see how an abnormal spike and slow wave activity is seen in a unipolar montage, and when we change it to the bipolar montage, we can see that there is something called phase reversal. See, this is coming down and this is coming up. And the common electrode between these two is F3. So we can localize that this abnormal activity is actually coming from the left frontal region. So this is called localization or phase reversal. Just some examples of absent seizures is a 3 Hz spike and wave activity you all know from your NEET PG preparation days. This is how an EEG abnormality of a myoclonic seizure looks like. This is how an EEG abnormality of generalized tonic-clonic seizure look like. I've already showed you how focal seizures they look like. Lastly, now I'll conclude my presentation over here, where I'll just talk about some guidelines for assessment of abnormal activity in EEG tracings. This is basically taken from an article written by Robert Malsbay. So just because you are seeing a sharp wave or a spiky form abnormality or a slow wave, just don't jump to calling it as abnormal. The first guideline says that every spiky looking wave is an artifact unless you have more than one good reason to suspect otherwise. So what I mean to say is solitary spiky form activity, unless proven otherwise, should be recorded as an artifact. Secondly, spike and sharp waves of cerebral origin, they always occupy a proper or a definable electrical field. So whenever you get an abnormal activity, say in F3, suppose I'll go back just a minute. Suppose you get an activity in F3, you will see that the same activity is rippled at FP1 and F7. So this is called a ripple effect. So always see adjacent electrodes, whether that particular spiky form activity is actually rippling in the adjacent electrodes or not. Clinically significant spike and sharp waves are almost surface negative initially. So please check for that. See over here you can see surface negative waves. By convention, most spike and sharp waves are followed by a slow wave or a series of slow deflections, as I told you previously also. Please ignore sharp or spiky events which can be logically explained by simple alteration in the voltage of the existing background rhythm. Don't jump to call it a spike or a sharp wave. And there are several types of physiological spike and sharp waves occurring during sleep. I told you about sleep spindles, which are typical triphasic waves. Then there are vertex sharp transients, which are typically looking like a sharp wave. Don't jump on to call them abnormal. The dictum which I have learned over a period of time in the last, say, almost 20 years that I've been working in epilepsy clinic and the EEG department is, please be conservative to report any EEG as abnormal. EEG has a good temporal resolution. Even if you report any EEG as abnormal, doesn't make a person to sue you. Because you can always say that maybe it's a time-bound thing. Nah? Right now, that abnormality was not there, but when the other person recorded, there was an abnormal electrical activity. So mere absence of an abnormal electrical activity in an EEG trace doesn't mean that you have not either recorded or reported EEG properly. Kindly remember this. So very quickly, the research application, if any one of you is interested, so we can take the EEG data and do a lot of computation analysis. These days, a lot of AI and other things are happening. We do noise reduction, classification, prediction, quantification, feature extraction. Not going into the details of this. We just got a patent while we basically worked with the Department of Computer Science and Engineering from BIT Mesra Ranchi, where we used the frontal EEG waves or frontal EEG activity and created an algorithm which can detect depression while a person is actually wearing a headband with the electrodes embedded into that. So this is just one example of what I'm trying to say. We can club them with the neuropsychological tools, which are gold standard for measuring cognitive functions. We can do a test, retest reliability, practice effect from test. I've told you about ERP, which is a non-invasive way of monitoring the brain processes with a good temporal resolution. We can do frequency analysis, time frequency analysis, topographic mapping. These are certain toolboxes which we commonly use when we are doing quantitative EEG recording. Again, I'm not going to the details of this. If anyone is interested, we can talk about it during the question and answer sessions. So to conclude, EEG has both temporal and spatial resolution, better temporal resolution. And my dear friends, there is a lot of scope beyond just doing EEG for epilepsy or clinical EEG. I'm sure I might have made my point over here by the end of this presentation. We can always do good group comparisons and we can add EEG with other imaging techniques, which is the future. So I would say that though I'm kind of passionate about using EEG, but it's not a thing to say that for neurobiological understanding of psychiatric disorders, EEG is something to look for. So these are certain further readings. Basically, I've already showed you UGIS. Then Niedermeyer is for EEG recording. No EEG, reporting is incomplete while using an atlas. So we at CIP use Kaibara and Bloom Atlas of EEG, which we've been using for many years. Thank you once again for the opportunity to all the members of Tamil Nadu State Branch of IPS, particularly Dr. Shivanand, for getting back to me, thinking about me. I hope you guys are not bored with this. I'll stop my screen share and happy to take questions if there are any. Over to you, organizers. Thank you.
Thank you very much, sir. Thank you for shedding light on the untapped potential of EEG, extending far beyond its conventional role in epilepsy, including the neurocognitive neuroscience and other fields. Now,
conclude, sir. So thank you, sir, NISHANT GOYAL, sir, for your active participation, and you have patiently given the explanation of the questions whatever asked by our postgraduates. And we thank all the organizers as well as the Indian Psychiatric Society, our members for active participation, and our postgraduates also, the present are also. Thank you all. Thank you.